start the presentation once it works.
Perfect. Thank you. And thanks, Peter. So I guess Peter's going to have to pay attention because I'm going to ask him to advance the slides at different times. So thanks, Peter, for doing that. Thank you guys for giving us the opportunity to talk a little bit about pulmonary rehab in the province, what we've been, what is it, what we've been doing, where we're hopefully going and stuff. And of course, this fits into the path of work very well, and you'll see that in a few slides. Who am I? So I wear a few different hats. I'm a professor of medicine at the university. I also direct the G.F. McDonald Center for Lung Health, which provides the main pulmonary rehab program in Edmonton, and now through a variety of sites with telehealth. And I'm also the scientific director for the Respiratory Health Strategic Clinical Network. So the next slide just details so we're talking about pulmonary rehab today. And this is a definition of pulmonary rehab. And on the next slide, I've highlighted the text. And you can see the long description, but really at the bottom, we're talking about a program that has patient assessment, tailored therapies, but really the focus is to get these patients through exercise training, education, and behavior change to promote long-term adherence to what we call health-enhancing behaviors. So we want them to adopt a more physically active lifestyle, better disease management, and all those sorts of things. Go ahead there, Peter. And go next slide too, please. Generally, we talk about three main components of pulmonary rehab. There's the education, and that can happen by group as well as one-on-one education. There's the exercise component, and then there's what we call the support component, which is not just the patient and the healthcare professional, but the patients also derive a lot of support from the group dynamics. And that's, a lot of studies have tried to simplify pulmonary rehab and so on. And time again, these are the three key components of rehab. You can't, for example, just give education without the rehab but without the exercise component. The outcomes just aren't nearly as good as when you combine all three of those. So the next slide details some of the common outcomes we see. This is a Cochrane review, so it's a big systematic review on the main outcomes from pulmonary rehab. And what we know is that time and time again, compared to usual care, rehab improves quality of life, breathlessness, fatigue, and exercise tolerance. And in fact, the Cochrane database system is designed to revisit questions as more data comes out. They've actually suggested they're going to shut down this review process because they have such good evidence that pulmonary rehab works, they don't need to do it anymore. And so really the focus is not anymore on does rehab work, it's how can we deliver it better, how can we improve access, so on. And the next slide is details some work that we did in both the American and Canadian group, looked at preventing COPD hospitalizations. And the slide after this is just some of the group data looking at a collection of studies. And these are sort of line and blob graphs, as we call them. On the very bottom is the red triangle, or sorry, diamond. And what you can see is it basically just looked at how effective pulmonary rehab is at preventing hospitalizations for COPD. And you can see the red diamond is shifted to the left, indicating that on average, patients that attend pulmonary rehab have a reduced chance of getting hospitalizations in the future. And in fact, if you look at the series of studies above that, the collection on the very, very top, that's actually the collection of studies where rehab was given within about 30 days of discharge from hospital. And what you can see is that's where the biggest effect is. And that kind of makes sense because patients that of course exacerbate tend to exacerbate again. So that's kind of the high risk patients. And again, if we target pulmonary rehab to those patients, we actually have about a 75% reduction in risk for readmission rates in the 6 months to a year follow-up. And so, this kind of information, of course, really supports the idea of moving service in the community to try and prevent future exacerbations of COPD. Next slide, and sort of why part of what we're talking about here is who needs rehab. The slide after this is the updated Canadian Thoracic Society guidelines for management of COPD. You can see the little steps. This was just published here about a couple of years ago now. On the bottom, we look at the severity of the disease, so we can look at lung function from mild to severe, our symptoms using the COPD assessment tool or the CAT, as well as dyspnea, and you're going from, of course, 0 to 5. And what you can see, of course, is that as the disease gets, the idea here is as the disease gets worse, you would add more therapies. And you can see pulmonary rehab sits right in the middle. Essentially, once patients start getting on inhaled long-acting therapies, that's around the time that patients should be getting pulmonary rehab. As far as dyspnea goes, you're talking about somewhere around a dyspnea score of 3 or so. So that's patients that are definitely being impacted by their dyspnea. We've done a lot of work at our center trying to understand, where's the biggest bang for your buck, which patients seem to benefit from rehab the most. And truthfully, from a quality of life and exercise tolerance standpoint, all patients seem to benefit. That is, we don't see a pattern where only the severes benefit or only the mild benefit. So from a patient side, we'll often suggest that any patient that is symptomatic, that feels like they're ready for rehab could certainly be referred to rehab and derive benefit. The next slide just highlights part of this infamous pathway work that you guys are all part of. And of course, this is the AHS COPD discharge bundle that's being implemented across the province. And what you can see is that number 5, that idea that we want to assess patients and see whether they can be referred to pulmonary rehab locally. And so the idea, of course, is that ideally every patient being discharged from hospital with COPD should be potentially targeted for pulmonary rehab. And ideally within that first sort of 4 to 6 weeks. And again, this was of course based on systematic review of the data. I showed you the one slide showing that if you give pulmonary rehab within 30 days, you have about a 75% reduction in readmission risk. And this was also based on expert opinion, and many clinicians probably on this line were involved in some of that as well. So, from a provincial standpoint, who needs it? Well, again, everybody can benefit from it. And from a AHS, health service delivery standpoint, we ideally would like to see all patients get pulmonary rehab as they get discharged from hospital. So the next slide, moving on to the next slide, how are we doing? And so the following slide details a bit of a graphic view of where we are across the province. We are part of a big review looking at where pulmonary rehab sites are located. Alberta, actually, you see there has a pretty good distribution. We'll talk about that in a minute. The next slide actually goes through some numbers. They counted up all the different spots available for rehab, and we have the capacity to serve about 10,000 patients. When you look at prevalence of the disease, we can only really serve around 1% of all the COPD patients in the country. You look at I should have put provincial data, and I'm sorry I didn't, but provincially, back of the napkin calculations, and Chantel will try and keep me honest, but we have about 10,000 hospitalizations for COPD in the province, and we have roughly about 1,000 spots for rehab. So we're doing better than average, but still, when you think about if every patient should get pulmonary rehab, we're not doing very, very well. And then another issue is that most of the programs are located in hospital settings. Now, the next slide details some of the encouraging work, and we'll get to that in a second, but this idea of trying to move some of the programs into non-hospital-based settings, and more research is needed to identify the best practices in these types of settings. So just the next slide then talks about our telehealth program. So we've had that in existence now for well over 10 years. This is a program that started as a pilot. You can see the yellow dots were the sites that originally started with our telehealth pulmonary rehab program. And essentially what we did is we used the video conferencing technology to provide physician consults at the start of rehab. So a patient could be in Fort McMurray, let's say, and sitting next to their allied health professional and seeing a pulmonologist via the video conferencing. Then we have the education pieces being live every Tuesdays and Thursdays. So you can see it in person here, of course, in Edmonton, or again, you would see it in the remote settings, and then the patients would exercise at their remote sites. And we did a large trial on this and showing that the improvements in quality of life and exercise tolerance were actually quite similar in our main program in Edmonton as compared to our other remote sites, suggesting that you can deliver this program remotely and again derive similar benefits with our patients. And so now we're working to scale and spread that, and I'll come to that in a second. The other thing that, of course, is another strength of Canada, the next slide, talks about, I'm sure many people are familiar with the Living Well with COPD program. This is a program that's really been the passion of Dr. Jean Barbeau, and it is, I'll be blunt and I'll say this remains the best education program for patients with COPD. The next slide is the slide that validated this work, and it was a while ago, but what you can see, this education program is really based on principles of self-management, and it's one of the only education programs that have demonstrated reductions in hospitalizations and also reductions in healthcare utilization following the education program. Admittedly, the program is fairly complex. So patients are to work with an educator for about 8 hours. But it again remains one of the strongest education programs for patients with COPD. So with that as a background, a few of us started talking about how can we improve the access to pulmonary rehab nationally? How can we move it from this traditional hospital-based to more community settings? And the next slide just highlights what was a major goal for the past few years: the development of a national pulmonary rehab program. And the idea here was to really design a high quality program that would facilitate best practice, and it could be done in a variety of settings. So that would include your main hospital settings, that would include remote sites, those could be primary care sites, that could be community rehab sites. But the idea is to try and deliver, of course, a high quality standardized program. So the next slide just gives you the idea of who was involved in the development. So it was the folks at the G.F. McDonald Center for Lung Health and myself, Jean Barbeau's group out of McGill, Roger Goldstein's group out of Toronto, and then Nicole and Michelle's group out of the University of Sherbrooke. And so what we actually did was we took the Living Well with COPD education module as the backbone from the education piece. We integrated the expertise that the group had on assessment, on program delivery, and so on. And we then had a series of feedback loops with patients and with providers, and trying to fan out across the country to get good feedback from a variety of places. And worked as well with the Canadian Thoracic Society, and they have since endorsed this program. So it's considered sort of the CTS supported program for patients to liver pulmonary rehab. So just to take a step back, we'll talk a little bit now about why did we standardize. So if we skip forward a couple of slides, so why did we standardize? There we go. Thank you. So this is, I've shown this slide before, but this is an editorial in the BMJ several years ago, and it, you can see the poor patient there at the bottom, and I like this picture because this typifies a typical COPD patient. They're given a list of instructions or prescriptions from one physician potentially and another physician, and oftentimes you see that as a patient goes through let's say the acute care visit with COPD, they get some education at the bedside, and then they might go to their GP or their specialist, and they might get slightly different education, and so it can be very, very confusing. And so one of the things that if we start to coalesce around a standard action plan, a standard education modules, I think it really, really starts to make it easier for the patient. Next slide deals with the other, I think, important aspect. So I was incredibly lucky to start working with some behavioral scientists early on with our program. And, so much of what we do in disease management is around behavioral medicine and behavior change. And when you work with these scientists, you have a much clearer, and I'm not one, so I want to be careful what I say here, but, it really opens your eyes to understand what's underlying the behavior change and how we really want to change how we deliver things and ultimately to facilitate that behavior change. Now, I'll give you one example. The next slide is one simple example. Again, if you think about rehab, the principle of rehab is, again, we're going to give them education and experiences and motivate them and do all these things, and hopefully they learn to manage their symptoms and ultimately, for example, be more physically active, because of course they all want to be able to go about their lives. They'd like to go golf again or dance again or whatever it may be. And so if we've done our job right, pulmonary rehab should fundamentally change that behavior. And one behavior, of course, is physical activity. So this is a study here just looking at physical activity measured by steps per day. And of course, we know that the guidelines for Canada, we're all supposed to accumulate 10,000 steps per day. And you guys all probably have Fitbits now. And hopefully you're doing that. You can see here with this group of COPD patients, they only accumulate around about 3,500 steps per day. But notice they don't get much better with rehab. And so this is an example, I think, of where we're not actually impacting the behavior for the patients. And when there was some discussion about this, and you see the quote at the bottom there, and that when we look at pulmonary rehab programs, they generally don't have much of a theory underlying the program and underlying the behavior change principles. So the next slide, and again, I'm not a behavioral scientist, so hopefully no one will catch me on something incorrect, but this is the work of Bandura, and this is what Living Well is based off of, and again, as an extension in this updated pulmonary rehab program. On the far right-hand side, of course, we have behavior change or performance. We want to change the patient's behavior, have them learn to manage their disease better, and so on. And a key driver of that is self-efficacy, or the confidence in order to do something. And Bandura would say that the key drivers of self-efficacy are these 5 components: mastery, vicarious experience, verbal persuasion, physiological state, and emotional state. So, of course, you want to get the patient to be comfortable, walking on, being able to walk up a flight of stairs, for example. You want to have them be exposed to other people doing it so they can learn that vicariously. You want to find ways to subtly, encourage them and ensure that they're able to do the activities. And obviously you want them to be in a comfortable state, not overly anxious, and so on. And this again is what drives in theory the behavior change. And what's interesting about this principle is, notice like knowledge per se is not one of those key drivers. And as I've reflected on our program, we often push knowledge to patients, but that's not, knowledge by itself is not necessarily going to change patient confidence and ultimately patient behavior. And so this, I think, was a really good experience for certainly our program, and to try and sort of better understand how we can get at that long-term behavior change with patients. So the next slide just is a bit of a principle, again, of what we're trying to do. So really using the Living Well program, adapting through rehab so you can get that vicarious experience, you can get that mastery performance and so on. The idea is that we're going to adopt the behavior change. We're going to adhere to that, and that will ultimately lead to long-term health outcomes. So patients will better manage their disease in the months following stay at a hospital and so on. So again, from a standardization point, that was a big thing, is to try and bring in that behavior change principles, have that applied throughout the program. And of course, if we put our AHS hat on, there's a few other reasons why we'd want to standardize. The next slide, we've all seen this before, the Health Quality Council of Alberta talking about dimensions of quality. And it talks about things like accessibility, appropriateness, effectiveness, and efficiency. And of course, we want to try and provide a program that is efficient, demonstrate its effectiveness. Admittedly, if programs are all different, it's hard to demonstrate that they're effective, and so on. The next slide highlights this relative to what the quadruple aim, and again, looking at things like improving care and streamlining the process, making it easier for the clinicians to deliver the program, making it more consistent, and so on. And we were doing this along the way, sort of, and of course got lucky that this became a priority as well for the pathway work. And the next slide is just the clinical networks end-to-end pathway. And Shelley Valère has nicely put pulmonary rehab as a foundation to all this. Again, the idea, of course, is that pulmonary rehab could be given to patients as they leave hospital. It could be delivered in primary care. It could be delivered earlier in the course of the disease when a patient is symptomatic but hasn't shown up in hospital. And so, some of this movement was going on, and we were like, again, we want to coalesce and ensure we have a package of program that's clear and defined and so on. And then, of course, the other things that were going on, as you've already alluded to on the next slide, is that this pathway was being developed, the order set was being developed, and of course, sites were now going to be sort of asked about their local pulmonary rehab programs, and we wanted to have the ability to provide that service if new sites wanted to come on. The next slide, in parallel to this, was some work provincially on community rehab and improving the model of care through allied health and community rehab groups. And so through the respiratory group, pulmonary rehab was identified as a service they wanted to standardize. And so it worked out really, really well for us as we were trying to sort of scale and spread standardized pulmonary rehab, that community rehab also saw that as an important goal. So the next slide just sort of highlights, sort of summarizes, again, why we've tried to standardize. Again, first and foremost, it provides a consistent messaging for the patient. For example, now if you're a patient that goes to the, is admitted in Edmonton to Royal Alec Hospital, for example, with their great CSI program, the education material you would get there is very, very similar to what we get in pulmonary rehab. So the patients can be discharged from the Royal Alec and come to pulmonary rehab and see the same handouts, the same instructions, and that kind of thing. Again, standardized program is based on best practices with respect to the CTS endorsed work, as well as the fundamental behavior change model. It supports things like Alberta Health, or Alberta Health Quality Health Matrix and the quadruple aim. Again, consistent with community rehab. What this also does allow is for some audit feedback for continuous quality improvement. I'll get to that in a little bit. And what the big vision we have, and I'll explain a little bit, is to try and really get a stronger business case ready for scale and spread of the program provincially. And so what we have done, again, historically our program has been called the Breathe Easy program. So we've operationalized the national program within our Breathe Easy program. And again, the goal would be to scale and spread that further across the province. So the next slide, just again, so how are we doing? One of the things we did is we ran an effectiveness trial on this new program. So we randomized classes, not patients, but classes to usual care, which was our old rehab program, versus the new program. We had just over 200 patients be randomized to one of the two programs. Or sorry, I was confusing. We randomized by class, but again, a total over 200 patients were part of the trial. What we saw, so through the standardized program, we have clearer slide decks, we have clearer instructions for the instructors. It's meant to be more conversational, interactive when we deliver the education. And we did a series of audits and saw, for example, that the new program allowed for us to achieve better learning objectives. We had a high degree of patient satisfaction. We looked at physical activity, quality of life, and 6-minute walk. Though the outcomes were actually similar to our old program, that's not a big surprise in some ways because I think we're already doing a fairly good program. But what's important to note is we do see in this program a change in physical activity after rehab. So that says that we are actually making real changes to the behavior, which I think is very encouraging. They're getting smarter. We measured that as well. They're getting more knowledgeable, there's no doubt about it. But again, we're also translating that to changes in behavior, which is encouraging. So where are we thus far? The next slide gives you a bit of an idea of the scale and spread so far. And I'm sorry, the map is not as clean as I'd like it to be, but that highlights the various sites that are now coming on board with our standardized program. So we have 19 programs as part of community rehab. We have 6 that are in partnership with primary care networks, and then 2 that are a part of Alberta Healthy Living. And so what we have is a process in place where through site visits and so on, we're able to align current programs to this updated standardized program. We've also done some exciting things. For example, in Edmonton zone, we now have a central referral process. So now when patients, historically we had a few different rehab programs operating in Edmonton zone, whereas now there is one standard referral process. All the patients are seen by a pulmonologist. and then potentially going back out to the community program. So I think it's a great model to maybe look at other large sites. We've also developed a QI database, and I'll talk about that in a second. So the next slide just gives us a bit of an insight and sort of summary as to oh, sorry. I'm missing there we go. I'm a little lost. Sorry. So where are we going next? We're now in conversations with Calgary and South Zone, again, about the interest to adopt this program. So we've identified a number of sites in Edmonton Zone, Central, Calgary Zone, South Zone, and North Zone for further implementation. Again, other sites may be able to support it in the future. And what we're really trying to do, and happy to say we actually just got a nice grant here a couple of days ago that will actually allow us to facilitate this work. And to me, the end game is a true business case that's developed to try and increase staffing and resources for pulmonary rehab. Most of the programs in Canada or Alberta operate with passionate clinicians that are local, that are already stretched pretty thin, that are doing the best they can, and they do a wonderful job of that. What we want to do is, demonstrate that this is an effective program, that we can scale it, that it not only improves patient outcomes, it also reduces healthcare utilization, and try to get real FTE assigned to that. And we recognize, we're not naive, that finances are changing perhaps in AHS in the coming year or two, but I think we all agree that shifting care in the community is the end game. So we're looking to develop a business case in the next 18 months or so to try and solidify more resources long term throughout the zones. In our case, we run as Edmonton is the central zone or central hub that beams our programs to a number of sites, and ideally probably need a couple other hubs like Calgary and so on that would be main sites for assessments and support of other programs. So the next slide just gives us a bit of an idea of sort of some of the insights and lessons. Again, we've been able to adopt or adapt the program to a number of sites, and we've done that while still maintaining the minimum standards. So we basically, as we go to different sites, we have sort of the minimum standards to be breathe easy, and then we have sort of suggested work with sites to obtain those. You'll see some data in a second from our outcomes of the program, and we're hoping to bring on more sites to provide the standardized outcomes, which I think is a very powerful tool when we look at trying to justify the existence of rehab and ultimately look for more services down the road. Again, I've sort of said this already. We've had some great growth. We're recognizing the need for probably some more hubs. And admittedly, on our side, some of the asks have been larger than some of the resources. But again, we're looking to try and change that long term. We did have a nice workshop about 4 months ago, and one of the things that came out of that and will be coming out soon is a development of a community of practice around pulmonary rehab that would be online, and that will be run through community rehab. So again, those are some of the lessons I learned from where we are currently. I'll just give you some to finish off. I'll give you some data and I'll update on that. So the next slide. Oh yes, this is what happens when you don't have your animation. See, so just to give you an idea again, why do we care about outcomes of our program? Well, you think back to the Health Quality Council and the quality matrix, and you can see here the three that drive it here, acceptability, effectiveness, and efficiency. We want to be able to show those outcomes if we ever want to try and improve access and ultimately resources for rehab. So what we've done on the next slide, we've developed a quality improvement REDCap database within AHS. And obviously Connect Care will eventually do this, but we can't wait 3 years for Connect Care to do this. And so what we have done is a REDCap database that's all within the AHS firewall. And it will hopefully, the data itself will be linked to Connect Care in the future, hopefully, or again, Connect Care will take over this job eventually. But as some of you, I'm sure, are dealing with Connect Care, data monitoring is probably a couple years away at least. So the next slide just gives you an idea of what we're able to look at. We're able to look at track both patient and program outcomes. We've created a bit of patient charting because our local site, as we got it going, wanted to minimize how many databases they use and so on. And the other thing that this program does is it allows for production of a standardized discharge letter. And that's become a big time savings for our group because we basically have a templated letter that comes out as a result of the data that goes into the database. Next slide is just a quick overview of all the data that we put in. And again, what we're looking to do as we scale and spread this further is other sites come on and potentially enter this data in. So basic demographics, lung function, medications, and so on. Again, what do your patients look like as they come in? Are they the same? Are they sicker? That kind of thing. Then we have objective functional status kind of measures, grip strength, sit to stand, 6-minute walk. And then we have some of the quality of life outcomes. We have dyspnea, MRC, COPD assessment test or tool, EQ5D and Watt LX. And of course, those are standardized AHS outcomes. Those are also outcomes that community rehab has prioritized. And so we've brought those in, or certainly the Watt LX we brought in to be consistent with community rehab. And then obviously things like class attendance and rehab progression. So I just thought to finish off, I'd show a couple of data slides just to get an idea of the power of what we're able to do with this. And hopefully get maybe some other sites excited to come on with this. The next slide just gives you a brief idea. This was just a snippet when we started around January 1st. So this is 4 months worth of data. You can see we had this. So this is basically just Edmonton zone, this particular slide. So you can see over 400 patients were referred. We were pretty good at assessing them. We have progress at that time about 150 patients. You can see our completion rate. You can see our denied, declined, and incomplete. So actually, when you look at our program, our incomplete versus our complete group is actually pretty small. We only incomplete about 20-ish%, which isn't bad. We also, of course, are looking at things like decline. As we have the discharge bundle, we're getting more patients that are coming to rehab right after exacerbation. Some of them didn't actually know what they were coming in for. And so we're learning about that a little bit. But overall, the decline rates actually remain pretty low, which is good. The next slide just deals with the proportion of patients we see. And yeah, the majority of our patients, as you'd expect, are COPD. But we have designed our program to be appropriate for all other lung diseases. So you can see bronchiectasis, asthma, ILD, and so on. And so the next slide. So this just gives you an idea of and I apologize, a lot of this data here, and I had this animated, but we couldn't do that today. So on the left-hand side is 6-minute walk. And just to focus on the 6-minute walk data as an example. So patients come in, and on average, they walk about 400 meters. That's pretty good. We get concerned if patients walk under 250 meters. That's considered pretty high risk of mortality and so on. So on average, our patients come in actually very functional. You can see roughly about a 40-ish meter improvement in 6-minute walk on average. And that's actually really good. The clinically important difference is around 30 meters. So we see on average a clinically significant improvement in exercise tolerance with a typical patient, which is good. And this is also where I think some of the quality improvement and protocols come in. What we do, just to clarify, is we have patients do at least 3 6-minute walks in the first couple of weeks of the program, and we take the average of 2, and that's what the data is here. So we know, for example, patients learn how to pace better, and so they'll naturally get better on their second 6-minute walk. And so the data that we gather here is the average of 2 pre and the average of 2 post. And the idea, of course, is to get a more consistent evaluation. So all the patients, you can see what's done at GF McDonald Center for Lung Health, which is, again, the Edmonton site. The 3 sites, I haven't named them. I know what site they are, but publicly I'm not naming them. And those are all rural sites. And not a surprise, we've seen this before. The rural sites have lower exercise tolerances, and they tend to have worse quality of life at baseline. And it's really quite interesting, even though they'll have the same lung function potentially, they will have potentially worse quality of life and worse 6-minute walk. But you can see all three programs in this case see a nice improvement in 6-minute walk. So definitely nice, effective programs there. On the right-hand side is the COPD assessment tool. So that's quality of life. In this case, the higher the score, the sicker you are. So you want to reduce the score. And again, you can see on average, the whole overall group sees a nice improvement in quality of life, and that's consistent across the remaining sites. And so this becomes really powerful if we're starting to look at, effectiveness. This right now tells you can deliver the program currently, in downtown Edmonton, as well as across 3 remote sites, and get similar improvements in 6-minute walk and quality of life. So, imagine how powerful that is if we had 10 or 15 sites and showing that it's pretty, the uptake is really, really good. So the next slide, similar, but now we've split it up by disease state. So this has been condensed across sites, and now we're looking at disease state. So you can see there on average, again, the change in 6-minute walk. You can see the different conditions. As I look at them, again, all diseases appear to improve their 6-minute walk. There's no apparent signal as far as one is worse than the other. We'll see that sometimes, but again, the change is similar. When you look at the COPD assessment tool, and I recognize that is a COPD specific questionnaire. We also have general quality of life questionnaires. You can see, so for example, asthma, COPD, IPF, they see a nice reduction or improvement in quality of life. The alpha-1 data sticks out a bit, but that's a sample of, I think, 2 patients. I think bronchiectasis, I think, is 2 or 3, and alpha-1 is about 2 or 3. So those are small sample sizes, but generally we see that the improvement in quality of life is consistent across the various diseases. And again, that would be important if we're doing a standardized program to ensure that we get benefit across the various diseases. So almost done. The next slide just gives you an idea. Again, what we're able to do with this is to create a standardized discharge letter. So if you're a remote site, you can actually put all this information in. If you put the information in, you get a nice discharge letter with pre-populated sentences and so on. It's a little bit longer than this, but I cut it off for the slides. Oftentimes clinicians always complain about doing discharge letters, so this helps, again, the efficiency piece. So the next slide, again, just to summarize, my crude summarizing, we know rehab is good. I think there's evidence now that standardizing is a better approach. We're looking to spread the Breathe Easy further. We're now at 27 sites. The next steps, again, would be looking to spread to more sites, integrate the quality improvement database to other sites. There's been interest, and there's obviously that some groups are working on home-based programs. And so I think one of the next steps we want to do is try to understand what's going on in the province on the home-based side, and better sort of define that, and better figure out how to integrate that to the standard outpatient program. What kind of patient needs home rehab? What would it look like? What kind of patient needs can go to outpatient rehab? What would that look like, and so on. And again, happy to say we got a grant, and we're going to be able to try and facilitate that work on the home rehab piece, as well as the business case side. So last slide, just to thank everybody involved. The top right is an image that we've used in the I know certainly in Edmonton zone, as we've talked about the integration of the COPD and heart failure pathway work. And by statement, their integration is complex. This work has been, I couldn't name everybody in this. I tried to name everybody, and then I had to get about 10-point font because this involves so many different people and so many different groups, and us all trying to work together. And I think we've done a good job of that. I think that there's been some great work with community rehab and others. But it is complex, and we're learning along the way. We've had made mistakes, there's no doubt about it. Locally, we've had Tina and Virginia work with the sites to try and scale and spread rehab. Des has been leading the quality improvement database. Roberta with her role in respiratory therapy has been really key on the community rehab piece. Obviously, we've had some great community rehab partners in the Edmonton zone. Celine Tash, Laura Mans, Darla Van Spiegen have been really important as we've looked at things like, again, the standardized referral process and try to bring the Edmonton zone together. And again, we've had great leadership in Central and Northern and Calgary zones now as well. And then finally, of course, the network has been supportive and key to this, and obviously the larger pathway work. Again, you can see I could list everybody, I could list all the pathway folks, but I wouldn't be enough font on this, so I apologize. So hopefully that gives you an overview of sort of what we've done and where we're hoping to go. I can talk more about the future now because we got a grant the data 2 days ago, so I'd be happy to talk more about that if you have questions. If you are interested in maybe learning about how you might want to bring on rehab in your site, the easiest person to contact to get that going would be Tina. There's an email there, and I'll stop there and we have some time for questions.
Thank you so much, Mike, for your presentation. It was really informative and just excellent. And it's really exciting to hear what's happening all throughout the province. So I will stop the recording now, everybody, and please feel free to ask questions, things that may be unique to your zone or your unique site, as Mike's here available to answer.